Okay, good morning. Welcome back to Favaloro Foundation University Hospital. On my right side, I will introduce the team, Dr. Lev, Gustavo Lev, Dr. Juan, our fellow, Eric, our technician, Matthias, the nurse. Fabian is a technical expert on the device that we are going to use today. Dr. Cotos, anesthesiologist, and Mariano, our anesthesiology tech. And behind the screen is Dr. Andres Rodriguez, who's gonna act as a digital moderator. I introduce Matthias, also the nurse. Let me introduce the case first. Let's go with the next slide. So next, is an 86-year-old male presenting with the abdominal aortic aneurysm. He has history of hypertension as dyslipidemia and a very long time ago, PCI. Next. So the ACG is under normal rhinosysm with some negative tests in the lateral wall. The blood tests are normal. The body mass thickness is normal. He also has preserved left ventricular ejection fraction. And in the abdominal echo, it was shown an abdominal aortic aneurysm, which has grown in the past year more than 5 millimeters, reaching the 51. And that's why the patient was referred to us for treatment. Next. So this is the CT scan with 50 millimeters in diameter abdominal aortic aneurysm with a significant calcification in above the renals and also below the renals with a short neck. It's a little bit taper, but not too much with 16 millimeters length. This proximal neck of this bilobulate aneurysm, as you can observe on the right of your panel. Next. Here in this slide, what I am showing to you is a significant calcification that we have also, not only in the abdominal aorta, but also in both iliac arteries, both common and also especially on the right side, on the external iliac artery, especially at the level of the bifurcation and also at the level of the common femoral artery. If you see in the bottom right of the panel, you can observe a significant calcification, especially at the bifurcation of the right common with the tight stenosis. So that's why we are going to predilate not only the bifurcation, but probably we'll do some touch there. Next. So this is the proximal neck, excuse me, with 19 millimeters in diameter at the level of the renals and 22, 26 below the renals. So we are going to use a 26 device, taking into account the proximal diameter, or I mean the renal diameter, where is also a significant calcification, as you can observe there. Almost 90 degrees of the circumference is calcified. Next. So this is the right iliac artery with a diameter of 10, with a length of about 56 millimeters. So that's why we are going to use branches of 13 millimeters in diameter for both sides. The common femoral artery is 8 millimeters and also with significant calcifications. Next. And this is the left iliac artery with calcium at the ostium and also calcium on the common, probably 90 degrees of calcification with a diameter between 8.6 or 9 millimeters in diameter. And then the external is acceptable with 10 millimeters on the common femoral artery, but also with significant calcification, especially on the posterior and posterolateral wall. Next. So in summary, it's a patient with a previous history of coronary artery disease with heavily calcified aorta with progression of this aneurysm. That's why after the heart team, the discussion and also taking into account the patient's preference, an EVAR procedure was suggested. And that's what we are going to do today. Next. So according to the anatomy that I have already presented, we are going to use a percutaneous femoral access with a surgical standby. Dr. Frau is always our support. And according to this calcification, we plan to use an ultra low profile device for these patients, especially for the access and also for such calcified iliac arteries and also small iliac arteries. we're probably going with the regular devices would have been a little bit difficult, not only for advanced, that probably we will not have problems, but for the retrieval of the nose cones of these devices, and then to closure the 20 French sheath on the main body axis, and 16 or 18 French for the contralateral side axis. Next. So that's why we are going to use this device, which is a 14 French device, which is a 3-modular design. It's an ultra low profile. It's 14 or 16 French according to the main body diameter. In this case, with the 26, it's going to be 14 French. And for the left iliac branches, it's 12 French axis. So I think it's acceptable for this situation with a lot of calcium and some difficult for closure devices. So the device is hydrophilic coating. It's a PTFE graft. The stent is electropolished nitinol. Next. So this is the configuration of the proximal part with a very closely positioned stent for a better sealing. Laser cut crowns with hooks for proximal fixation. So we have marks where the PTFE starts that we are going to see on fluoro. Next. So this is the other characteristics according to the diameter, a comparison with other devices, the hydrophilic coating, the 14 French sheath. The device also have retained introducer's sheath, so it's also important. We don't have to use any additional sheath during the procedure. And the tip capture mechanism, which is proximal, and I'm going to show you, allows us to open the body, or the proximal part of the body, and when we are sure about the position, we can release the hooks. Next. So this is a comparison where we are with this device in comparison with other devices, the old Zenith. Now the Alpha Zenith is lower profile also, the Endurance, the Excluder, and the Minus, which is probably one of the lowest profile device in the market, at least here in Argentina. Next. Proxima, next. So this is the configuration of the main body. The 2 branches, the main body has a length of 45 millimeters, the proximal part, and then both branches, the homolateral is 15 millimeters. So at the end, it's going to be a main body of 10 centimeters in length, and the contralateral leg is 35 millimeters. This length of the branches also allows us to move each iliac branch to shorten or to enlarge when we are not precise with the measurements. So next. And then all these marks, the proximal marks, which should be precisely below the lower, below the renal ostium. And then the contralateral mark with this 7-shaped marker that we have to see on like an I, a capital letter I. This is going to show you that this contralateral stamp is exactly contralateral. And then we will go back to this during the procedures. And then each stamp or branches have different mark for the overlapping with the iliac branches. Next. Let's go back to the lab, and so we can show you what we have already done. Let's go to the first angio, and then I will ask Gustavo for some comments. So first, this is the first angio. No, excuse me, the first one. So under angio and echo guiding, we try to find the spot where we don't have calcium for doing a precise puncture there to have a proper sealing with the closure device. We also are using the vessel navigator with the angio CT that you are going to see soon, the CT scan overlapping with the angio. If you can show from the screen the right inferior panel, you might see the CT scan there. Will you change the configuration, please? Okay, we will try to go back to this. Let's move with the ancho. And then next, we introduce the ProbStar once again, because when we have such calcified common femoral arteries, we rather like to use this device, being very careful to have all the needles inside the sheath, which is one complication if they go up outside of the sheath. You are observing now on the inferior left part of the panel the overlapping of the fluoro and also the previous CT scan on the vessel navigator. There you can observe all the calcification that I was describing on the common iliac arteries, on the abdominal aortic, and also on the common femorals. Next. Then we did the angiography, and then we introduced also the homolateral sheath. Next. Once again, guiding by echo and the angio, taking care of the needles. Everything went okay. Next. And there we made a puncture below on the SFA, just to leave a wire there for protection for this biggest sheath. But as you can observe there, we couldn't cross, probably due to the calcium, with the regular J wire from the 6 French sheath. So we changed and we deployed there an Terumo hydrophilic wire, leaving this Terumo wire, which is outside here, below my hands for protection, just in case we have here. You can observe here, there's a Terumo wire below the 11 French introducer sheath. So it's here. The puncture is exactly where my finger is here now. Is catch by a halter here, and it's catch against the skin to prevent any movement. And I'm gonna leave this wire until the end of the procedure, just in case we have a complication. Next. So then we have introduced 2 stiff wires that are side by side, and we have prepared for balloon predilatation and the common femoral artery. I think this is the last, no? Yes. So Gustavo, could you make some comment?
Yes, Oscar, thank you very much. I think that this is the right case for this kind of patients. It's an octogenarian patient, and the endovascular treatment showed us in most of the studies less comorbidity and mortality in elderly patients. So first of all, I think that this is the right treatment for this kind of patients. Then the choice of this kind of
let's go.
Yes. This kind of prosthesis is also, I think, one of the best.
Slowly. Okay, let's go.
This option because of a low profile and the narrowing out arteries we have at the femoral section. So I think that this prosthesis will be a very good option for this patient.
I think you can inflate only 1 or 2 because it's too big.
Which one?
8 and the homolateral one.
Okay.
They are the bifurcation, just 2. No, not too much.
Yes.
3.
Okay.
Okay, I think it's okay. The introducer set is gonna go perfectly. No, Gustavo, you can retrieve the balloon, leaving the wire.
Okay.
Wait a minute. Yep. So once again, we invite to everybody to make comments or questions on the system. So Dr. Rodriguez is gonna bring the question to us, and we can comment or answer if we have the answer. If not, we will say we don't have it. Saca este, Gustavo.
Yeah.
So now we are going to retrieve both balloons. I'm going to introduce the right coronary catheter just to mark the left renal artery. For the introduction of the device that we are going to show you very soon. Patient is under conscious sedation under control of Dr. Cotto. He's very stable.
There's also very few publication in randomized trial, but very high experience with these prostheses. Once published in Journal and Vascular Therapy recently in this year, and with very good results. The last one with 41 patients with 100% clinical exit, and with a 10% type 2 endoleak. So
okay,
I think that it's a promising prosthesis.
Yeah, we don't have too much experience because it was introduced in the market on Argentina not so a long time ago. So we are doing some cases. We have, I mean, acceptable experience. The performance of the device is okay. We still need some long-term follow-up. So once again, remember we have two wires there on the right of the aorta. One is the stiff wire, the amplas wire. We're going to introduce the device, and the other one is gonna be left there outside the device. Remember, it's for protection of the introducer cells. So probably we can bring, Gustavo, the device here. Yes. So we can show you here. We can release from the package. We have flashed the device. You can observe this is a very low profile device. So this is the introducer sheath from here to here. Okay, perfect. And then this is the commander. Maybe if you go a little bit lower here, you can zoom here. Okay, perfect. So we have here a security device that we have to push up. And then after that, we can clockwise here to release the main body of the device. When we get the position, we had to move this second security part of the device. And here is counterclock, and then pulling a little bit to release the hooks. So, and then when we finish the delivery of the body, we have to push here in this part of the device to retrieve the main body delivery and leaving the sheath in place where we will introduce the homolateral iliac branch. So let's come here, please. Hold the groin.
Are you going to show the markers?
I will show you on the floor, yes.
On the floor, okay.
So Andres, once again, if you have a question, please bring to us. Let me put here, okay. So here, one of the, we have two anatomical challenge. One is the proximal neck, calcify, little bit taper. You can observe how easily the device is advancing. We might have zoom now on the device and we focus on the markers. So let me show you the markers we were talking about. So it is here. We have like an R configuration. This is orientation of the contralateral stump in posterior. If you rotate here like a 7, it's gonna be on anterior. If we put here like a capital E, it's gonna be on the lateral side of the delivery. So you can observe here this capital E. Now let's focus to the proximal part del cuello. So the aorta has angulation. These markers where the tip of the right Shatkin catheter is positioned are the markers where we have, or actually the PTFE is starting. So the PTFE is exactly below of the markers on the on the lower limit of these dark markers. So we might have to have a test. We lost the position of the renal. Let me try again. We don't have enough curve. Let me try again. We have the calcium there, test. Test. So we have the renal there. Test. Okay, so it's almost in coincidence with the upper limit of the vertebra. Answer, Gustavo? So we are a little bit lower. We have to go exactly to the limit where the calcium is. Probably the calcium is the better marker. I will show you the calcium here. This knot of calcium is probably the lower border of the renal artery. Is that okay?
It's like our road mapping.
Okay, but Fabian is telling me something important. While I was advancing, I lost the orientation of the device. Once again, if you see here, it's now on again in a configuration of an R. I had to rotate counterclock to get the eye orientation again. So now that
test,
you might test, Gustavo. I think the position is okay. I'm gonna move these markers up here, these markers, approximately, and then I wanna start to release. I have to push a little bit. It's gonna move forward a little bit. I have to keep the tension to see the orientation of the contralateral stump.
I think that the right catheter is a bit low.
Will you test? So probably it's a little low. So let me check. Fortunately, this catheter is losing the position. So I have to leave the markers here. So then I can pull a little bit. Because the marker is over the ostium, but remember the PTFE is starting below the markers. And it's moving my catheter because it's so tight, the anatomy. Test again, Gustavo. If instead of hemodynamic, you can share the CT scan where we have also an orientation. Could you share? Exactly. Test.
The eye.
Test, Gustavo. So I think the position there is okay. Test. Let me see. Test, Gustavo. Okay, I think it's okay there. Let's see next. Test. Okay, we can observe here the calcium. Más arriba o más abajo? Okay. He suggests me some millimeters up. Okay, there. Not pushing, not pulling. I'm gonna release the last part. And now you see, no. Okay, let's do a final ancho up. Okay. So left renal artery is okay. So the situation is okay. Hold me the sheath here. Tenelo ahí. Ni empujar ni soltar. I should open a little bit more. And now the contralateral stump is okay. ¿Ves, Gustavo? No empujes, ¿eh? Okay. Suéltalo. And now, it's okay.
You're going to release the free flow.
Yeah. I have to rotate this blue, unfortunately, here, holding the device. Are you sure this? have to make.
Would you like me to help?
Let me do it with this. Yeah, now it's released. Perfect. So now we are in control. We need an hydrophilic wire. So Erika is gonna go here. Abajo. Okay. No tanto. Contralateral. And let's try, tenemos rotador para esto, el blanco.
Yes, we have.
Un poquito oblicuo por aquí. Ok. Mostrarme que se vea más todo.
This product is not also a low profile. You can navigate very well.
Yeah.
Isn't it? So for tortuosity, short neck, angle.
I'm not sure if I am in. Hopefully,
I
yes.
think that it would be very useful for these difficult cases.
Yeah, I think we are in. Mostrame más abajo, sacale un poco de zoom. We will check it. We are going here. And we can rotate here. Wait a minute. That we are inside. We are doubtful about that because it was a hydrophilic wire, but we can perfectly go out. But moving freely there, we are sure that we are in.
This is the Doll maneuver.
Yeah. So bring me the unplugged wire. Yes, please. Okay, excellent question. Which are the potential complications? First, vascular access is always a potential of complication. Saca el zoom un poquito. Because big sheath can always complicate. Okay, this is number one. We can have bleeding. We might need, a cover stent. We need surgical repair, retroperitoneal bleeding, and any other occlusion, late stenosis that we have some cases. This is a potential of complication.
Are you going to size?
Yeah. Then the possibility of complication would be to have a type 1 endoleak. For type 1 endoleak, we have predictors. One is proximal neck, short necks, taper necks, angulating neck, heavily calcifies. So here, this is a case with moderate to high risk for proximal endoleak. Proximal endoleak could be solved during the procedure or later on. Leave it there. Moveme un poquito más. Aquí, okay. Or later on with the implantation of a cover stent or something like this. Or a proximal cuff or a bare metal stent implantation to increase the radial force of the device. This is one possibility. The other are distal endoleaks, especially when you have dilated iliacs, short common iliac arteries. This is a priori not a high risk in this patient. Row mapping. Then you might have embolizations. You are working inside an abdominal aortic aneurysm. So you might pone oblicuo para acá. Vamos a hacer otro. Para. So you might have the distal embolizations or solo la mitad. Or abdominal embolizations. Renal failure. Of course, if you occlude the renal artery, it's a complication. You have to try to open it immediately. In this situation, it's important to use SIM catheters going from the top of the device or from the brachial access or radial access with a low profile catheter, trying to re-enter to the renal artery by side the device and to deploy the stent there to move the device to the true lumen and to release the ostium of the renal artery. We have some cases in the past it could always happen when you have two short renals and you are very borderline with the device. So, and then many other clinical complications. Here, what we are trying to do with Gustavo is to measure how many, or which is the distance from the device, which is here. And then we have 1, 2, 3, 4, 5, 7 centimeters. And so the device is 100 centimeters, 3 for overlapping. So I think we are going to be perfect there. We don't have to cover here the hypogastric artery because it's totally unnecessary. The common iliac arteries are calcified but not dilated. We don't have to go over the internal. So disadvantages. Well, this is another very good question. Is which are the disadvantages of this device? We don't know exactly so far so many because it's a very new device for us. I think as many other devices, especially peripheral devices, when you decrease the profile, for sure you are decreasing the radial force. So probably this is one of the main limitations. You agree on that? Okay, Juan, here. Gustavo is going to retrieve the, no, put this way, te va a salpicar. Gustavo retrieve the pigtail. And this is probably one. The second one is a long-term follow-up. Actually, it's not a limitation of the device. It's a limitation of the information. We still don't have it. Or at least here in Argentina. Probably we had to ask Chinese colleagues that I was watching last night, very elegant cases done there. Probably some colleagues there have experience or longer experience with this device. Any other, Gustavo, that you can imagine as a complication or I mean limitation of this device?
No. It's a very good device, and I think that we feel very comfortable with it.
So let me show you something. Let's go from below. So first, to be sure that we are on the area where we want to land, which is here, near the hypogastric artery. So in this situation, we can take out the roll mapping because interfere on the vision. So we are okay there. So maybe I can move a little bit. And we can concentrate there. Let's sacar el roll mapping. Okay, we have a marker there. And then we have to see all the overlappings if they are okay. So they are okay. So once again, hold it here. So I'm going to release here.
You rotate, clockwise as the other one.
Okay, I'm going to keep there, trying to keep these markers together. Fabian is watching the proximal marks. I am watching the distal mark, trying not to go too low. Too low, exactly. So now I can release the proximal part. Is that okay? So I can open here. So I can release there. You observe a movement in the proximal part. So now I can release here, pushing or pulling, trying to correct the distal landing zone. But I think we have a perfect landing zone there. Okay, everything is open. I'm going to advance the sheath. You can observe there. Wait a minute, because I have something. It was released, it's okay. Now I have to disconnect here. And you are going to hold, no, the other hand here, the other hand here. Let me see that everything is going out very smoothly. Okay, Gustavo, keep doing. Okay. Okay, perfect. So now we can, the balloon is not possible. Go frente. Now I'm going to continue releasing the main body, actually the homolateral branch. Let me take all this out. Okay. Keep rotating. I'm gonna release the homolateral branch, and it's totally free. Okay, so I had to pull this. Yeah, now I have to disconnect from, mostrarme arriba. The introducer sheath, now it's free. Do we have to recapture or anything else? No, this is okay.
No.
I have to pull it. It's okay. Let's see, being very careful that the delivery system is coming in. Perfect. Juan is holding the sheath inside. And Gustavo is gonna continue to retrieving the device. Perfect.
We like the pigtail marker?
Yeah, let's check with the marker so we have plenty of time. So please, more questions. No, espera. So let's see.
Going to check the homolateral.
So one question is from me to Fabian. If I had to use the CODA balloon or some similar balloon, I can go through the 12 French? No, ¿puedo ir con el CODA por el 12? No, how to go from here? Hercules. So we have to use the Hercules balloon, not the regular CODA balloon, to go from this low profile sheath. I think it is water. Okay. Wait a minute, Gustavo.
This is contrast.
Contrast? Okay.
Yes,
okay.
this is contrast.
Let's
this one, eh?
Okay. Sorry. So we are going to make an injection here or something. Little lower. So probably we should go. Well, I think there is okay. Come up in there. So let me espérame. So we have 1, 2, 3, 4, 5, 6, 7 again. So the calculation done by the CT, hold it. It's okay. Once again, it's 13 by 100 millimeters. So Gustavo is going to prepare.
Are you going to retire the security wire, the hydrophilic security wire?
No. Okay, perfect. Gustavo is asking me if we should retrieve the security wire that we have outside. No, I will leave it there because it's a hydrophilic wire. Sorry for the noise. Yeah. If we lose the position, then it's going to be difficult to reposition in this wire in case of bleeding. Anyway, remember, it's a 14 French sheath and a 12 French sheath. So it shouldn't be, but it could be. So Gustavo and Juan are flashing the contralateral device. Okay, we show you. So important to hold. Juan is holding the outer sheath because in this hydrophilic sheath, as any hydrophilic sheath, sometimes moves out and it's a complication. So what I have to show you here, that here we have some connector that should be exactly in the outer sheath to be, to be plugged, to be sure that we are working perfectly. Let me show you. So I'm pushing here. It is supposed to enter. It is supposed. Like now. I felt the click. It's okay? Okay, and now I have to advance everything together. Let me see, where are the markers? So markers are there. Let's concentrate again On the proximal part that I am not seeing, let me do Cine. There. So I think the position is there. Is that okay? Okay, so we have a marker in the monitor. So we are sure where we have the hypogastric artery. Here we shouldn't be so close to the ostium. It's unnecessary. So I'm going to take out the road mapping and I will concentrate on the regular fluoro. And we can leave in the inferior part of the monitors once again the CT scan. I'm going to release the security. Once again, I have overlapping of the markers and I am releasing. As you can observe, everything is moving out all together, the external sheath and the internal sheath. Is that okay? Okay, probably a little bit higher. No, it's okay. It's okay. It's open.
Going up.
Yeah. This marker should coincide with this. Is that okay? So at this, well, one of the limitation that we can add here is no so radiopack device.
Mm-hmm.
So probably should release the proximal part now, so preventing any movement. You will observe there the movement on the proximal mark. And now I'm keep going, delivering all the branch. And it is okay. Now I will push a little bit. I'm going to disconnect here. The lagomita. Yeah, hold it here. Moving out, being careful. Everything is moving smoothly and Gustavo is gonna pull. Let me hold it. And now we can do an ancho just to have an idea, or probably we can do a balloon. No, let's go with the Hercules balloon, especially for the proximal neck.
This is if you want to show the balloon.
It was quite similar to the balloons, elastomeric balloons that you know, but it's different because the profile is lower. Hold me here. Yeah, thank you. Acompáñame para arriba. I'm going up. I'm going to inflate here on the proximal neck. Okay, no, just trying to see the rectangular configuration is more than enough.
You don't post delayed.
No, it's just to how to say, remodeling.
Remodeling.
Yes. Yeah, this is the word. So you see that it's conical. Mm-hmm. We'll bet that you have a perfect ceiling and on the proximal edge. Now I'm gonna do an inflation on the connection of the stump here, exactly there, very smoothly. Then here where it was the stenosis, if we have resistance there, we can go with the
non-compliant balloon.
A non-compliant balloon, we should, I think. You told me that we have 9, ¿no? 9 tenemos,
9,
¿no?
10 or 12, whichever.
¿No hay? 9, 10 o 10 tenés? 10? You give me 10. Okay, sácalo, Gustavo. Hold it, yeah. So I'm going to inflate there. Yes, because if we still have a stenosis there, we also can deploy the stent if we have. So give me the pigtail just to see how is the final outcome, especially in the upper part. Okay. See, we will balloon in the contralateral side, but let me check it. I'm worried about the proximal ceiling. So probably if we have a not an important leak, it is okay. So let's see what's going on. No, I think we still have some leakage there. not so important. So we will do two things. First, we are going to dilate both branches. Let me the 10 and the 8 to dilate the contralateral side. Let me the amplats again. And then we are going to dilate the aorta with the 18 millimeter balloon at high pressure. But to be sure that I am going not to, not bigger than 20. But I think this small leak is not important here. I think I'm not going to use a bare stent. The position of the device is okay. So I'm going to wait probably 30 days, get the patient back for CT. And if it is persistent, then we can deploy a huge bare metal stent there. So let's inflate here. And okay, now let's go.
Yes. Sorry, I cannot see.
Yeah. 1, 2, 3, 4, 5, 6, 7, 8, 10.
10.
Perfect. I think it's okay.
Okay.
And let's go with the 8 millimeter balloon from the other side. So I am using non-compliant balloons to produce a little bit bigger radial force in a very calcified arteries. I think it is showing that our, let me see, where is the balloon? No, it's
okay. Kissing?
No, we did that. I don't know where is the balloon. Advanced the wire?
Yes.
Let me see. Okay, let me again. Okay, now. Okay, let's go there. We post dilate the
10,
I mean,
12?
Yes, the overlapping and then
10.
Let's
10.
go distal. Okay. It is perfect. Deflate the other balloon. Deflate. Okay. Deflate so. Let's hear once again. No.
Mine.
9. Yes, perfect. 10.
10.
Okay, let's go. Okay, so while deflating, please retrieve this. I am holding, yeah. And give me the 18 millimeter balloon. Dame el 18. And you can retrieve the other one.
Okay.
Gustavo. Yeah.
Now?
Yeah. It is okay.
Give me 18.
So with this balloon, we are going to use a syringe, a regular syringe, and we inflate with our hand. And we are trying to go at high pressure, trying not to damage the bifurcation of the device. So the proximal part is inside the main body, but not affecting. Okay. So here, when you have a proximal leakage, you might have to decide whether to put a cuff if the device is proximal, a second inflation like this at high pressure, but with a non-compliant balloon. You cannot do this with the Hercules or with the Coda or with any of the elastomeric devices. Now Gustavo is gonna pull it. And the other possible solution, if it is a huge type 1 endoleak, it's never good, but sometimes you have to wait, especially in very old patients, especially in patients with significant calcification in the aorta, where to deploy a huge stent could be also dangerous. You can occlude the renal arteries. You can dissect the abdominal aorta. So that's why if it is not a catastrophic leak, you should wait for some time, bring the patient back and to decide. Okay, let's go again. Okay. Much better. Similar, I would say.
Similar, yes. All right.
So we also have some porosity there. So the position is okay. So I'm not using. Do you agree, Gustavo? You
Yes.
rather like to deploy the stent?
No. Perhaps we can inject inside the prosthesis
To see porosity?
Yes.
But with a lower volume, probably 15 or something like this.
Yes.
See. Let me do a test inside the device just to check porosity. Let's inject. We have some. You see.
Some. See.
Yeah,
There's
so
some
probably it's a combination of both.
Yes.
So
perhaps.
we should wait. Let's put the Amplatz wire here.
Yes.
So any additional maneuver would be, I mean, a potential solution or a potential complication. Okay, the care of the patient is going to stay in the hospital until tomorrow just to take care of the vascular access. Then the patient is going to be under DAPT for 6 months at least. Patient should undergo, let's go here, River de Parina.
Yes.
Move here. No.
We usually double anti-aggregate this kind of patient with clopidogrel and aspirin for 6 months, especially because of the leg limb. So we suggest that regime. And we usually control this patient with angio CT 3, 6 months, especially 6 months and 1 year, and then one study per year. So in order to especially study not only the endoprothesis but endoleaks. Okay.
So Gustavo is going to remove the sheath. I'm going to close here. One is going to hold it. We still have some bleeding here. We still have a suture. So probably we should do something, Gustavo, just in case. To put a 6 French sheath.
Yes.
Because if we have bleeding, we can put an angioseal.
Okay.
Before closing the second knot. Patient is still under full heparinization. So let me go with this. Let's
in some patient with renal or kidney disease, we
can
perform one angio CT at 1 year, and most of the control are by echo, abdominal color echo.
So now we are sure that ceiling is going to be reached with the suture-based device, so we can pull everything out, the wire and the sheath, Gustavo. Remove the wire.
Okay.
Let me pull this. Solta. Let me push the knot. So we have only a small oozing. This is, I'm going to say, the huge benefit of this device. So hold it. I'm going to close from the contralateral side. Let me move.
So you usually prefer to use Prostar rather than Proglide or Angioseal in calcified lesions.
Baja un poquito la camilla.
Isn't it? Yes.
Yes, because we have explained here.
The needles are...
No, and we have the old generation Proglide. We are waiting for the new one. So with the new one, probably we can do this case, no, from there. We can do these cases because the needles of the new ProGlide are stronger. Yes. No. Okay. Okay. So, okay.
Do you use the
we'll do the same.
Okay.
So I will hold it. Gustavo, retrieve the sheet, leaving the wire, and give me the 6' sheet.
Okay.
Ian Matias, who remember us. Anyway, this is a 12 French. All the old guys like myself and Gustavo used to hold it by compressing old French in the old area of interventional cardiology.
Yes.
But anyway, we'll do it better here. So now I am closing. With one suture is okay. So let me tie the second one and I will retrieve everything out. And we are almost done. Remember, this is 86-year-old male. So we have to be very careful for any additional maneuvers, for any additional procedure. So retrieve everything, Gustavo.
Okay.
We still have some oozing here. Let me push. Suéltalo, déjalo sangrar. We have here some small bleeding, not too much, but we have to compress. Hold it. Suéltalo. Okay, so Gustavo is gonna hold here. The procedure is done. I'm gonna move. After, vení de este lado, Gustavo, y comprimir un poco.
Yeah.
So we have some oozing. So we have to hold it because it's a 12 French sheath, nothing special. And then we will do 2 sutures on the skin, and we will do it. This is which is the big sheet. It is okay. So we can cut the sutures. Leave it there. Okay. I'm gonna move to the other room.
And we can get away this wire.
Yeah. This is important to show. So mostrame aquí. So here the wire, which was outside. So we are pulling. It's very easy to retrieve. So movete para tu lado. So one is gonna hold it for a minute. I'm gonna suture the enter side. Gustavo is gonna hold there. It's gonna fish. So this is the small incision in a very old patient. You can observe here. Podemos hacer una ACT, una ACT para saber cómo estamos y ver si hay que revertir más heparina. Okay, perfect. I will leave it here. I will say bye. So we'll stop here for a couple of minutes. No, you have to make some big effort, just to hold a little bit. And I'm gonna move to the lab number 4. I think it was an excellent procedure with a new device in a very old and sick patient with heavily calcified vessels. We can observe the very good trackability and navigability of the device, especially the trackability, and also the precise deployment. The proximal neck was challenging. We knew it from the very beginning. So now we have to compress here and finish the case. Gustavo is going to finish. Bye.
Bye. Thank you.